Start, sir.
Yeah. So, Jignesh, shall we start?
Yes, sir.
Okay. So, hello and very good evening. I'm Dr. Ashok Jaiswal from Zydus. And at the outset, on behalf of entire team, German Remedies Zydus, I wish to extend a warm welcome to each one of you to this webinar on the topic Management of Acute Upper GI Bleeding. Acute upper GI bleeding is not so uncommon clinical condition. From the various clinical trials, what we have understood, the incidence rate of acute upper GI bleed might be ranging between 60 to 100 cases per 100,000 population. And further, the major clinical concern is the mortality associated with acute upper GI bleed. The clinical trial have reported almost mortality rate of 14% in patients in hospital with acute upper GI bleeding. In recent past, we have witnessed a remarkable advancement in the management of acute upper GI bleeding, with advancement in newer technologies in the endoscopy, and the pharmacologic landscape has been changing. And what we believe, with this advancement, we will be having better and better clinical outcome while managing our patients with acute upper GI bleeding. Today, we are honored to have an eminent faculty and consultant in the field of gastroenterology amongst us. Let me take this opportunity to introduce you our today's speaker, Dr. Umesh Jalihal. So Dr. Umesh Jalihal, his DM gastroenterology from TNMC and BYL Nair Hospital, Mumbai in the year 1999. And in the same year, he also completed his DNB gastroenterology. Presently, Dr. Jalihal is working as a director and consultant gastroenterology at Karnataka Gastroenterology Center, Bangalore. He is also head of the department in the Department of Gastroenterology at Columbia Asia Referral Hospital, Bangalore. He has vast 25 years of clinical experience in the field of gastroenterology, and he has many publications in his credit in national and international journals of repute. His major area of interest are emergency endoscopy, diagnostic endoscopy, therapeutic endoscopy, and endoscopic retrograde cholangiopancreatography. He has many awards in his credit, including Government of India National Merit Scholarship. So without taking much of your time, I would request Dr. Umesh Jalihal to take us through his journey in the field of gastroenterology and in particularly management of the acute upper GI bleeding. Dr. Umesh, over to you.
Speak. Speak. Yeah. Good evening, everybody. Am I audible?
Yes, sir. We can hear you. We can see your slides on the screen.
Yeah. You can see the slides and can see me as well.
Yes, sir.
Okay.
We can see you. We can hear you clearly.
Okay. Thank you. At the outset, I must thank Zydus as well as German Remedies for organizing today's webinar. Today's webinar, the topic is the management of acute upper GI bleed. Actually, we all are going through this COVID pandemic, and because of that, a lot of this elective endoscopy, elective surgeries are almost on the kind of a back foot. They're very, very less sparingly done. But we somehow cannot say no to emergencies like upper GI bleed and cholangitis or any foreign bodies. So these are the GI emergencies we continue to handle. So irrespective of what's going on. And because of this lockdown or limited movement of on account of this COVID pandemic, I think these webinars have become very, very handy, and it's brought most of us, the friends, the speakers and colleagues very close. And I think we take this opportunity to just share our experience on the management of acute upper GI bleed. As Dr. Ashok Jaishwal has already given the introductory remark, the upper GI bleed or GI bleed is a medical emergency or a GI emergency. It can present to a family physician, or a GI physician or a surgeon, and sometimes patients can present in emergency rooms or the casualty of many of the tertiary care centers. So whenever we hear or see this upper GI bleed patient, at least when patient gets this GI bleed, the people around the patient and the patient themselves become little panic, because when the blood comes out through the mouth and when they vomit, so it evokes some kind of a panic reaction. But we need to, as doctors, need not panic, and we have to take care of these patients. So for that, we have to have a very good understanding about its various aspects. So this is one of our patients, I think a few years back, presented to our ER. He's a 40 years old gentleman who was alcoholic, presented with a massive upper GI bleed. He had blood vomiting, came to the emergency room, and actually when we did the endoscopy, he had the bleed from the lesser curve. Mostly I recollect that it is a small ulcer or a dulophyse lesion. So when we are going to discuss the upper GI bleed, we will discuss it under the following headings. That is, its definition, classifications, epidemiology, etiopathogenesis, clinical features, complications, diagnosis, and the management. So in the next 40 minutes or so, we will try to touch upon these points in the upper GI bleed management. So what are the types of GI bleed? As we are already mentioning that today we are dealing with upper GI bleed. If there's an upper GI bleed, there must be a lower GI bleed. So when we call it as upper GI, when we call it as lower GI, when we call it as obscure. Anything that bleeds from the esophagus, stomach, or duodenum, that is proximal to the ligament of Treats, is called as upper GI bleed, and anything lower down is called as lower GI bleed. But surprisingly, if the bleed happens from this small intestine, it can present as obscure GI bleed, and if it is if it can be overt or it can be occult. What we will probably touch upon during our discussion. If you look at the magnitude of the problem of this upper GI bleed, roughly about 50 to 100 cases per 1 lakh persons per year is the incidence and the prevalence, but this can vary from center to center. There are some centers which report as high as 170 cases per 1 lakh persons. And if you look at the hospital admissions, at least I think 100 out of 1 lakh hospital admissions could be because of the GI bleed. Upper GI bleeding the most common compared to the lower GI bleed, something like a 60-40, and it's mostly common in elderly age group, elderly men. The mortality in non-variceal bleed is something like 5 to 10% starting from 1970 onwards, and we have come a long way in the last 3 to 4 decades. A lot of changes in terms of management, pharmacotherapy, endoscopic treatment, ICU treatment, and many kind of innovative methods have come. In spite of that, I think mortality continues to be hover around 5 to 10% in non-variceal bleed, whereas it's about 30% when it comes to variceal bleed. So what may be the presentation in upper GI bleed? The GI bleed can present as hematemesis, that means blood coming in the vomitus. There's a red blood coming in the vomitus, which indicates it's an active bleed. Or it is a coffee ground vomiting. That means patient has probably bled and stopped when he has come to us. Our patient may present with hematemesis associated with melena. That means not only there's a red blood, but there is a black stools. Melena means black tarry stools. That means there's an altered blood. So that means the patient has had some time following bleed from the upper GI source, and the blood would have traversed through the small bowel at least for more than 8 hours, and you need some time for the blood to come out. So it will come as black stools, maybe because the acid hematin. That is means when there is hematemesis and melena, the bleeding is little more brisker as compared to the coffee ground vomiting. So patient also can present with the hematochezia and hematemesis. Hematochezia is nothing but passing fresh blood in stool associated with hematemesis. So that means patient has got probably very brisk bleeding in the upper GI tract, and probably the transit time in the small bowel and the colon is less than 8 hours. So it comes as red blood. So that means probably it's bleeding from the major vessels or large caliber vessels. If the patient on presentation presents to us with a shock, with the exsanguination of the blood, that means the patient must have had a very massive bleed from a large caliber vessel, or some aortoenteric fistula, or from one of the gastroduodenal artery branches. As contrast to this, patient can present sometimes with small intermittent bleed. When that is there, patient may not present with either the hematemesis or melena. It can be breathlessness, and if you happen to examine this patient, patient may be having signs of anemia. So these are the various presentations. So if you look at the signs and symptoms, so on presentation, patient may have dizziness, confusion because of the low blood volume. Patient, as I said, may have, in addition to hematemesis, abdominal pain. If there is a presence of abdominal pain in a GI bleed, it is either because of a peptic ulcer bleed or because of the portal vein thrombosis in case of the variceal bleed. And if the blood loss is more, the patient can have signs of dehydration, cold clammy, skin pallor, presence of hypotension, tachycardia, and if you do an abdominal examination, patient may have palpable spleen, and in the systemic examination, patient may have signs of chronic liver disease. So on presentation, so how to categorize the patients who has got good outcome, who is likely to have a better outcome, who is likely to have the worst outcome. So there are certain parameters which will give us a broad hint that if these things are there, patient is probably likely to have adverse outcomes following this GI bleed. If the patient is elderly, associated with comorbid conditions, and compared to non-variceal bleed, if it's a variceal bleed, as I said, if there is a red blood in the vomitus or in the stool, and shock on presentation, requirement of large amount of blood transfusion, active bleed on endoscopy. Looking at ulcer characteristics, I think we'll come to that in a few minutes. If there is a jet bleed or profuse bleeding from the bleeding source, these patients are likely to have adverse prognostic factors. Most of the hospital bleeds, like bleeding that may happen in the ICU, in the dialysis units, or in the chemotherapy units, tend to have the bad outcomes. Patients requiring surgery, that means most of the patients who have had large amount of bleed, or patients may have had associated perforation or obstruction or malignancy, so will fall into the category of bad prognostic factors. So what are the various causes of non-varicial upper GI bleed, or the bleeding sources in general in a case of upper GI bleed, because till we do the endoscopy, many times we will not be able to make a distinction whether this patient has got a variceal bleed or non-variceal bleed. So bleeding source could be from the esophagus, mostly the reflux esophagitis, grade C, grade D, or it's a varices or Malrivis tear or Cameroon ulcer, malignancy, or in the stomach if there is a bleeding source, most probably because of the peptic ulcer or erosions or Malrivis tear or Dulophy's lesion, or again malignancy, portal gastropathy, etc. In case of duodenum, it can be bleeding can be because the ulcer or diverticulae, and occasionally if patient has had some graft surgery, aortoduodenal fistula is most likely maybe the cause, but these are all not very common. Less commonly, the patient may also bleed from biliopancreatic source. When there is a bleed from the liver, it's called hemobilia, and if there is a bleed from the pancreas, it's called hemosuccus pancreaticus. So most of the pseudoaneurysm in pancreatic pseudocyst or a large pancreatic malignancy can result in GI bleed called hemosuccus pancreaticus. If you look at the split or the occurrence of various causes of GI bleed, mostly the non-variceal bleed accounts for about 70 to 80%, whereas variceal bleed accounts for about 15 to 20% of the conditions of the causes of the upper GI bleed. And uncommon causes, as I just now mentioned, could be hemobilia, Dulophy's lesion, and hemosuccus pancreaticus. So these things can vary from center to center, and depending upon whether it's a tertiary center or whether it's a small nursing home, the type of GI bleed can vary. Is there any possibility whether we can differentiate on presentation the bleeding is from the upper GI source or lower GI bleeding, or it's from the lower GI source? When there is a hematemesis or the blood coming into the vomiting, there is no doubt that it is from the upper GI source. But when patient presents with only melena, so it's sometimes difficult to say whether the bleeding is from the lower upper GI source like duodenum, or it's the small bowel or the right colon. So because from the investigation standpoint, it's important whether we have how to resuscitate these patients and whether we have to do the endoscopy first or colonoscopy first. So it's important to make at least clinical exercise as to what may be the probable cause before we actually start evaluating these patients. If in doubt, you pass a rice tube and find out if there is a returning fluid is blood, it's a hemorrhagic aspirate, there is no question that it's a upper GI bleed. But in about 16% of patients, even if it's a duodenal bleed, duodenal ulcer bleed, the RT aspirate can be non-hemorrhagic. So this is something we have to keep in mind. And one important thing is, if you happen to examine the abdomen and auscultate, there will be blood is an irritant in the stomach, and it actually promotes the rapid intestinal movement. So if there is a hyperactive bowel sound, possibly it's the bleed source indicates that it's from the upper GI source. And if you do the lab investigations like BUN, blood urea nitrogen, and creatinine, BUN to creatinine ratio will be higher in upper GI source as compared to the lower GI source. Coming to the history and physical examinations, which are very, very important in the possible finding out the possible cause or source of GI bleed. If a patient has got bleeding diathesis or a coagulopathy, it's very, very important to elicit that history. And some of the patients like cardiac patients or neurological patients having CVA, being treated for CVA, may be on anticoagulation. So patients suffering from some rheumatological conditions may be having on a long-term non-steroidal anti-inflammatory drugs. So they may have, they are likely to have non-variceal bleed. So if a patient has undergone the arterial bypass graft few years back, so may have bleeding from there. And in case of certain abdominal malignancies like CS, stomach, pancreatic malignancies may have the skin manifestations, that is blackish discoloration in the axilla and the groin, what is called as acanthosis nigricans. Or if there are any pigmented skin lesions in certain AV malformations in the GI tract conditions associated with these lesions like Osler-Weber-Rendu syndrome or hereditary hemorrhagic telangiectasia. Inoxanguline purpura can present with abdominal pain and skin lesions or skin pigmentation in young patient. And patient on examination, if you find an abdominal mass, could be because of splenomegaly or abdominal malignancy, could be CA pancreas or CS stomach, and the presence of abdominal tenderness would probably indicate there is an associated peptic ulcer disease or the perforation. So on general physical examination, this is one of our patients few years back. This young girl had the lip pigmentation and sole pigmentation. When we scoped this patient had Peutz-Jeghers polyp. And this is the kind of skin manifestations we see in the case of inoxanguline purpura. So this is the borrowed slide. You find that lip pigmentation, and if you do an endoscopy for such patients, you may find the AV malformations in the stomach and the duodenum. This is a patient, you will see that skin lesions called pyoderma gangrenosum, and on evaluation, this patient could be having inflammatory bowel disease. So that brings us to the next step, that is resuscitation of these patients. So when the patient presents to us for the first time, it could be managed in the ER or in the ICU, depending upon the patient's condition and the rapidity of the blood loss and the situation or the setting where we are in. So most of the times, if it's a massive bleed or a large epizootic bleed, these are the situations where we actually treat them. So when it comes to the treatment, so we have to have a quick checklist of treating these patients by way of ensuring the good airway, because they can have aspiration, they can have tachypnea. Sometimes they might require urgent endotracheal intubation, but most of the times they would not require. But in only extreme situations, we should be careful and we should be quick enough to establish the airway. And we have to look at their vitals, especially with the blood pressure. If they're hypotensive, we have to quickly start them on some fluids. You can actually start whatever fluid you get it. It could be crystalloid or colloid, and you have to aim is to replace the lost volume. So that's very, very important. And side by side, you can start them on proton pump inhibitor infusions. We'll come to that in a little bit of a detail in the next few slides. And they should be given antibiotics because they can have infections, especially in the variceal bleed, known for spontaneous bacterial peritonitis, etc. And the next other important thing is the insertion of the nasogastric tube. It will help us in assessment of the GI bleeds, source, plus the rate at which the patient may be having the bleeding. If it's a red blood returning fluid is hemorrhagic, when we give a Riles tube wash and the returning fluid is hemorrhagic, most probably it's an active bleed that's going on. If it's a coffee ground, as I said in my previous slide, it's probably bled and stopped. And so that and plus when we give a Riles tube wash, in a way we are also preparing the patient for possible endoscopic evaluation. The visibility when we do the gastric lavage by placing a large wide bore Riles tube, it will help us in proper evaluation of the bleeding lesion. So it's very important to place a large bore IV cannula, especially 16G cannula should be placed if possible in both arms. And if patient is hypotensive, if you are in the appropriate setting, you can even place a center line so that it will help us in fluid management. And we'll have to quickly give proper credence to the vital signs and draw the blood for routine investigations. In this, we are more interested in hemoglobin, hematocrit, BUN, creatinine, blood group, cross match. So this is very, very important. Hematocrit in the initial stage prior to the bleeding and immediately after bleeding will not drop. This is an important point we have to keep in mind. It will be somewhere around 45 to 47. Whereas if you measure the hematocrit after 48 to 72 hours, there will be hemodilution and there will be drop in the hemoglobin by about 1 to 2 grams over the baseline, and there will be drop in the hematocrit. And also we have to measure the input and output. It's very important to replenish the lost blood volume. So that brings us to the next question, that how do we assess the risk of these patients and also do the while we are doing the resuscitation, because we have to think of the treatment strategy, not only the pharmacological agents like proton pump inhibitors in case of the non-variceal bleed. In case of variceal bleed, we have to give them the drugs like terlipressin, somatostatin, and octreotide. Besides this, we also have to plan an endoscopic treatment, and we need to instruct the endoscopy technician and the nursing staff or the endoscopy team to be ready and to prepare the appropriate sclerosant. If you are suspecting non-variceal, we have to probably tell our the assisting nurse or endoscopy technician to prepare the 1:10,000 adrenaline. If it is variceal bleed, we used to do sclerotherapy a few years back, but sclerotherapy is now going out of vogue, and we tend to perform endoscopic banding. So that's what we need to do. Besides this, we have to do the risk stratification. For the risk stratification, there are several scoring systems across the globe which have been actually put in place. But the commonly used ones are the Glasgow Blatchford scoring and the clinical or complete Rockall scoring. And also we have what is called as AIM-65 scoring and certain neuronal network scoring, but they're not very routinely used because they're very cumbersome to use. So these two scorings are used in many places. So Blatchford score helps in the initial pre-endoscopic assessment, and whereas Rockall score helps in both pre-endoscopic as well as post-endoscopic treatment assessment, risk assessment. So what the Rockall score includes is the parameters are the age, presence of shock and comorbidities, the overall diagnosis, and endoscopic findings. So if you have the comorbidities such as the cardiovascular system involvement, or there is a renal involvement, the scores become higher, and presence of the higher stigmata of bleed on endoscopy will push the patient to higher scores. So on Rockall score, if the score is less than 3, it indicates good prognosis, and vis-a-vis the score when it is more than 8, the risk of mortality is as high as 50%. So, for example, if you look at the Blatchford score, which takes into account the BUN, hemoglobin, the blood pressure, and the heart rate, if they are within reasonable limits, so the patient probably falls into low risk category in terms of the rebleed, the hospital stay, and need for surgery, and the complications. So under such circumstances, we may decide to treat such patients on outpatient basis instead of admission to ICU. So overall management includes, this is just a bit of a summary again: resuscitation, pharmacological forms of treatment, including proton pump inhibitors and the pharmacological agents in case of pharyngeal drugs. We will come to that in a minute. The endoscopic methods could be thermal methods or non-thermal methods or mechanical methods. And in certain situations, we may have to resort to surgery or intervention radiology procedure like angioembolization. So if you look at the common treatments of peptic ulcer disease, bleeding peptic ulcer disease, the commonly used agents are pharmacological agents, that is proton pump inhibitors. We have the proton pump inhibitors like omeprazole, lansoprazole, pantoprazole, esomeprazole, and rabeprazole. And mostly we use them as infusion to begin with, as a bolus dose, 80 milligram, whether it's omeprazole, esomeprazole, pantoprazole, followed by 8 milligram per hour infusion in the first 72 hours. Subsequently, we can switch over to BD dosage, maybe oral for 14 days, and subsequently OD dosage. When it comes to endoscopic treatment in the non-variceal bleed, we have many forms of treatment. We will try to see whether we can actually go into the details if we get if the time permits. Otherwise, I will just probably give you a kind of overview. I'll just touch upon them, and I'll show you some of the relevant videos. So they could be, thermal methods like monopolar coagulation or bipolar coagulation. Mostly it's a bipolar coagulation rather than a monopolar. We can use a heater probe application. What heater probe does is we have a gold probe. On the tip of the catheter, you have a needle. On the tip of the catheter, you have a titanium and a Teflon sheath. When we actually use high current like 15 to 20 watts, it can vary from stomach to the duodenum depending upon the settings. There will be generation of high current, and it causes kind of a coagulative necrosis. And in the process, the bleeding vessel gets charred, and there will be obliteration of the bleeding site. Next is the hemoclips. So these are basically the metal clips made from the steel and nitinol alloys, and they can be through the endoscope. And there are many companies. We have easy clip, you have a resolution clip, and they can vary in the size. It comes starting from 15 to 20 millimeter when it's fully open. So you have so much of tissue to approximate between the these clips. And also we have another clip called as OTSC clip. This is not through the scope, it is outside the scope, just like a banding device. We have a padlock clip, we have a Ovesco clip in case of bleeding from the ulcer, large ulcer bleed. If you are suspecting the crater, the arterial bleed, especially from large caliber like 2 millimeter and above, especially if there is a fibrotic base, we can use these kind of clips. Argon plasma coagulation is a very innovative method of treating the bleeding if it is there from a large surface, if there is associated coagulopathy, and such situations, you can use this APC. So an important discussion or point in the discussion is why acid suppression is very important. When there is a bleeding, either from the peptic ulcer or any source, there will be the bleed stops because of the clot formation. But in the stomach, we have acid and pepsin, which will ultimately dissolve this clot. So there will be early dissolution of this clot, and this helps in this results in rebleed even if it is stopped. So we have to give medication which will suppress the acid, which will maintain the pH in the stomach above or around around 6, so that the clot that is formed on the ulcer bed doesn't get dissolved. So these are the drugs, that is proton pump inhibitors, which are commonly used for acid suppression. How do they do the job? proton pump inhibitors. We all know that there are proton pumps in the parietal cell. Parietal cell is present in the gastric epithelial lining, and this is the parietal cell, which will help in the extrusion of the hydrogen ions into the gastric lumen. This can be blocked by these proton pump inhibitors as compared to a H2 receptor antagonist. Proton pump inhibitors block the acid at its final common pathway. So it will bring about a complete acid suppression as compared to H2 receptor antagonists. It's needless to say that drugs like sucralfate and antacids are not going to be that useful in the treatment of peptic ulcer disease bleed. Word or two about H. pylori and proton pump inhibitors. So H. pylori is a very commonly seen organism, especially in our country. Most of us have H. pylori in our stomach. The prevalence of H. pylori in India is something like 60 to 80%. So whenever there is a GI bleed, we have to test for H. pylori by way of taking the gastric mucosal biopsy, especially from the antrum. That's what is called as a rapid urease test. And quickly you can get the results in about 20 minutes. But one point we have to keep in mind in the setting of a GI bleed, as blood can be kind of an inhibitor, and even especially when you give acid suppressants, the rapid urease test for H. pylori can be falsely negative. So we have to be careful in the interpretation of these results. H. pylori can cause the GI lesions such as antral gastritis, peptic ulcers, and gastroduodenal erosions, which can result in bleed. Besides this, it also can cause mild lymphoma. So whenever there's any GI bleed, we have to test for H. pylori if it's positive. Once the bleed is controlled, the patient should be given H. pylori eradication treatment, which includes mostly a triple drug regimen or quadruple regimen. Most of the times, triple drug regimen is sufficient. It's a combination of 2 antibiotics and 1 PPI given as BD dosage from 10 to 14 days, depending upon the situations. So the next common conditions or parameters that can contribute for the peptic ulcer causation is non-steroidal anti-inflammatory drugs. So what do? They cause mucosal ulceration, and there will be erosion of the small caliber or large caliber artery in the submucosal plane, so which results in bleeding. Similarly, the antiplatelets like clopidogrel or aspirin or ecosprin, which are given mostly in the setting of cardiovascular conditions or CVA, neurological conditions such as CVA. It's often we find that these patients are on these antiplatelets, sometimes dual antiplatelets, if especially patient has undergone the cardiac stenting or a PTCA in the recent past. It's even if there's a GI bleed, sometimes very difficult to stop these antiplatelets. If a patient has no pressing indications like recent cardiac procedures like PTCA, we should stop the antiplatelets, especially the clopidogrel has to be stopped, and ecosprin, if possible, has also to be stopped. If you cannot stop, you can give up to 75 to 80 milligrams of ecosprin. Sorry. The next category of drug we see is anticoagulants. Most of the times, again, the setting is the same. The anticoagulants could be novel anticoagulants like warfarin and low molecular weight heparin, or sometimes these newer oral anticoagulants such as apixaban, rivaroxaban, or dabigatran are being used. Anticoagulations per se will not cause the mucosal damage, but if there's a mucosal damage, it can predispose for bleeding. So hence, we have to be careful. If there's any GI bleed, we must stop antiplatelets, anticoagulants, and non-steroidal anti-inflammatory drugs if it is possible, as we continue to give them proton pump inhibitors. That brings us to the important aspect of treatment, that is endoscopy. Here I've shown in this slide the how we have to take care while doing endoscopy. It's important, especially in the corona time, because endoscopy is considered as a high aerosol producing procedure. So we have to not only take care of ourselves, we have to take care of the endoscopy team and the patients themselves. So what we have done is we have done a modification here. If you see, it's a very low cost. Here anyway, it's my picture, but the headgear is missing. That is something we have to take care. Here it's my old picture. We have to use a headgear, completely cover ourselves. What we N95 mask can be used, and on that we can use a face shield to cover the face, protect the eyes, and on top of that, you can use the complete uh, PPE kit. When it comes to the patient, we have used just a protector sheet, which is used for endoscopy um, report cover. It's easily available in the endoscopy units, and you make a small hole here, and the mouth guard or bite guard is placed through that hole, like this here, so that anything aerosol coming, or when the patient breathes, the anything that comes from the nose is blocked there. But there's one problem we continue to have, especially when the patient coughs, the aerosol still can come through the mouth. To counter that, we have made some innovation. We have made just application of the gloves. Gloves actually is tied like this, and the part of the glove which covers the thumb is just cut here, and through that actually we can place the endoscopic tube. So the endoscope distal insertion part can go through that, and we can intubate the esophagus from there then on. So this innovation is very important, because some of us have to do the endoscopy and take care of ourselves. And while performing the endoscopy, there are a lot of aspects we have to answer, we have to keep in mind. What is the optimum timing of the endoscopy? Is it 3 hours, 4 hours, or is it an urgent endoscopy, or can we do it as an elective procedure? And there are many studies which have shown that the optimal timing of the endoscopy is something like around 12 hours. If you there are people who have tried to do it much earlier than that, like varying from 4 to 6 hours, but there's no additional benefit. But you should not actually delay it further unless there are some valid reason. But if there's an ongoing bleeding, we must try to scope these patients as early as possible. So while doing the endoscopy, what do we use? The drugs. In case of variceal bleed, we use a sclerosant called polidocanol, or sodium tetrahydrosyl sulfate, or called STD, or absolute alcohol. In case of non-variceal bleed, we use drugs like epinephrine, which is diluted like 1:10,000. And we can also use certain hemo powders like hemo spray. And in case of fundal varix, we use cyanoacrylate glue, which is a fluid and becomes quickly solidified by way of polymerization. And also we can use fibrin and thrombin. So while performing this endoscopic treatment, is one mode of treatment is sufficient, or whether we have to use dual mode or multiple modes of treatment in achieving the hemostasis while we are treating the ulcer bleeds. This is the schematic diagram which shows how the ulcer bleed happens, especially in case of mucosal ulceration in the submucosal plane. The small caliber, the small or large caliber artery gets eroded, and there will be bleed, profuse bleed initially. Following that, there will be blood clot, and quickly the blood clot will disappear, and it will become a sentinel clot, and the clot disappears, leaving behind an ulcer with a clean base. So people have looking at the endoscopic appearance of the ulcer. the morphological appearance of the ulcer, can we predict that is this a high risk lesion or is it a low risk lesion? Because it's important what kind of treatment has to be performed for what lesion. So people have looked at, if you see this lesion, like here, there is a jet bleed, and here in this lesion you have a ulcer with a visible vessel, and in this lesion you have the ulcer covered by blood clot. So these three lesions constitute a high risk bleeding lesions. That means the risk of rebleed in these three lesions is higher. Not only that, it can have a longer hospital stay and other adverse outcomes compared to the ulcers with a clean base. So this is called as, it's classified using Forest class, and in this Forest class, stigmata of bleed are classified as 1A if it's arterial jet bleed, and if it's oozing, it's called 1B. If it's a visible vessel, it's 2A. If it's adherent clot, it's a 2B, and 2C if it's a black spot, and clean base, it's 3. So as I said, the rebleeding will be higher in the first two categories compared to the last category. So it's important to use the endoscopic methods quickly, which are very effective. And many studies have recommended that when there is a bleed on endoscopy seen, or if there is a visible vessel or adherent clot, probably we have to use more than one method of hemostasis, endoscopic hemostasis. This is a slide which shows the same lesions, jet bleed here, there's a slow bleed, and this is a visible vessel, blood clot, clean place, ulcer stomach. So that brings us to the various methods of endoscopic treatment in the non-variceal bleed. This is the gastric ulcer with a visible vessel treated with thermocoagulation, and this is 4 weeks later, the same ulcer, how it is seen. This is the patient who had DU bleed. You can see a adherent clot here. So that brings us to some newer and recent methods of treatment of endoscopic treatment. Hemostatic powders. Till recently, we were not using. In the last 4 or 5 years, especially when we are unable to pinpoint this is the bleed source, or if the bleeding source is not properly tackled endoscopically, or if there is a large area of bleed, or post polypectomy bleed, or post instrumentation bleed, we can apply for a quick hemostasis, use this hemostatic powders. What we commonly use is this hemo spray, and it's available in India as well, and approved by US FDA. There are 2 other agents which are not available here in India, Endoclot and Ankafed blood stopper, available mostly in Turkey because they're developed there. This is how we actually apply them. This is a gun, and there's a catheter, and the powder goes and just falls on the bleeding lesion. And this is after achieving the hemostasis. You can see the powder covering the mucosa. And here, this is the kind of a mechanical barrier which is formed on the ulcer clot-bearing area. Sometimes when there is you have done a hemoclip application, but still there's a bleed, under such circumstances also you can apply the hemospray. So this is a, let me show you some of the jet bleed treatment. This is a sclerotherapy done way back, I think 10 years back. Ultimately, we had to, we achieved hemostasis, and this is few days later, we just did a check endoscopy. We can just see the ulcer without the bleed. These are some of the duodenal ulcer bleed with a small clot there. This is a sclerotherapy, and this is a sclerotherapy in progress. This is a sclerotherapy in progress. sometimes sclerotherapy or epinephrine injection alone may not be sufficient. Under such circumstances, we have to use some mechanical hemostasis methods like the hemoclip application. You can see here there is a bleeding point. This is the hemoclip, and it's applied here. This is a heater probe, as I mentioned in my previous talk. I think I'll have to probably hurry up because I think I have another 10 to 15 minutes. Dr. Ashok, you can inform me if there is any time constraint. Otherwise, I'll be just going ahead. I think probably I'll require another 15 minutes. Is it okay? Or if you want...
Can we cut down maybe somewhere around 7 to 10 minutes for your presentation?
Yes, yes.
We can, because we have some certain questions as well from the audience.
Yes, yes.
So if you can give some time for the audience question answers as well.
Okay.
Because I can see certain questions have already come up for the discussion.
Okay. Yeah. Since we are covering the both non-variceal and variceal bleed, I think it's taking a little more time, but I will, finish it quickly.
Yes.
So this is the hemoclip application, continuation of same, and this is the, again, duodenal ulcer bleed, doing a sclerosant injection, that's epinephrine injection. And after epinephrine injection, we actually put a clip, and again, we did the hemoclip, epinephrine injection to achieve hemostasis. That's a little bit of a problem. 1 minute. Slide is not moving. Well. Sorry. So what I'll do is I'll just move on to the non-variceal bleed. I'll show you just some of the treatment principles. The drugs used in the treatment of variceal bleed are vasopressin, glypressin, somatostatin, octreotide, terlipressin, and these are the esophageal variceal pictures. And this is the dose. Initially, we give 250 milligrams of somatostatin, and we give an infusion later. Initially, we used to do endoscopic sclerotherapy. We have started doing only esophageal variceal ligation in the last 10 to 20 years. And this is the esophageal variceal video. You can see the esophageal varices. The varices are classified as by Baveno classification or modified packet classification. And this is the banding of this esophageal varix. So this is how we achieve the hemostasis in case of this one. Esophageal varices. That brings us to the next question, that is treatment of gastric varices. Gastric varices is slightly different from the esophageal varices. It's a high flow system, and you can see here the gastric varix, which has got a bleeding. And here we use glue, which appears like India ink. It is fluid outside, and when we inject, actually, it will become solidified when we actually inject it into the varix. So it becomes solid like a cement. You can see the glue cast in the second video. So this is one of our patients following glue injection, had a bleed. Actually, this is an ideal case for endoscopic ultrasound treatment by way of coil application. So this is following the glue injection into the gastric varix. This patient had massive bleed, but ultimately, since we had already done 2 injections, Probably there was a little bit of a delayed polymerization. We achieved the hemostasis ultimately. Hemodynamically, patient became stable. Later, just a little bit of, you can see this large bleed as we inject. So fundal varix is sometimes bothersome, and we have to be extremely careful. You can see here, this is how it can bleed. Yeah, sometimes if there is a large bleed like this, especially in the esophageal varix, we can place endoscopic stent called Danish stent. And in certain situations where there is no gastroenterologist available, we can place a Sengstaken black mood tube. And this is one of our patients who had bleed from the second part of the duodenum following polypectomy. This is another patient of ours, had hemophilia. You can see here, there is a blood around the papilla. And when we did the ERCP for this patient, there was a cholangiocarcinoma. There was a stricture in the bile duct, and we had to place a stent to achieve the hemostasis. Sometimes bleed can be from the small bowel. This is a small bowel, and we do what is called as video capsule endoscopy to find out if there is a bleed from the small bowel. And sometimes if it's not possible to control the bleed with conventional methods, we use an enteroscope to control this bleed. You can see there's a bleed here. We have used the enteroscope assisted sclerotherapy. So that brings us to the summary slide, last two slides. So when you have a patient of upper GI bleed, we need to resuscitate and transfer to the hospital in the appropriate setting and subject them for that Blatchford score. If there is a less risk of bleed, then do probably routine investigations and discharge those patients with oral drugs. If there's a higher risk of bleed, then subject them for upper GI endoscopy. If it's non-variceal bleed, do a Rockall score. If it's a lower score, we can just give them PPI treatment and stop NSAIDs, eradicate H. pylori, and discharge home. If they have got a higher score, and give a PPI infusion for about 72 hours and give a H. pylori eradication, stop smoking and alcohol if the one is indulging in any of these habits. And if there is a rebleed, and do a repeat endoscopy. Vis-a-vis this, if there's a variceal bleed, do endoscopic hemostasis. Along with that, like banding or sclerotherapy. Along with that, also give pharmacological agents like somatostatin or terlipressin or octreotide, and reduce the portal pressure. And also give them secondary prevention with the help of beta blockers or isosorbate mononitrate. If there is a rebleed, again, tackle them with repeat endoscopy. So to summarize, I conclude by saying that upper GI bleed is a bleed which occurs in the upper GI tract proximal to the ligament of Treats. The brisk bleed can happen with hemodynamic instability requiring urgent attention and resuscitation. It's important to differentiate whether it's a upper GI bleed or lower GI bleed, or it's a variceal bleed or non-variceal bleed, if you want to plan the treatment, especially drug treatment or endoscopic treatment. If endoscopy is a must investigation in while managing this upper GI bleeds. In addition, we have pharmacotherapy and surgery, and at times we may have to resort to intervention radiology procedures. Antibiotic prophylaxis is an important adjunct treatment besides H. pylori eradication treatment, especially in the case of non-variceal upper GI bleed. Thank you. I think we have come to the end of my talk, and if there are any questions, I think we will take them.
Yes, sir. So thank you so much, for taking us through such an excellent presentation, which was very much clinically relevant. I mean, whatever the aspect you touched upon in your presentation, they all were clinically relevant. You shared your real-time clinical experiences and your case studies and some of the patients. How did you manage those patients? So thank you so much. Yes, we have quite a bit questions, sir. So with your permission, I will take those questions.
Should I stop sharing my screen?
Yeah, you have already stopped, I think.
No,
You
no.
can stop.
Yeah, I think, yeah, I
Yeah,
stopped.
you have already stopped, sir.
Okay. Fine.
So
Yeah, go
we
ahead.
have got a question from Dr. Kishore Krishanji
Okay.
from Arsapur. And doctor wants to know what should be the role of banding in in variceal bleeding.
Yeah, the endoscopic banding is a time-tested treatment options in a variceal bleed. And in the initial stages, at least I think when we were students, DM students, I think 20, 30 years back, people used to say that sclerotherapy is preferable, especially when there's an active bleed. And if there is a bleeding has stopped, then only people used to do the banding. But nowadays it's become a very common technique, and people have kind of mastered this technique of endoscopic banding, and it's very easy to perform, and has got very less complications compared to sclerotherapy. In fact, we have uh, recent publication which shows that if you do the banding in the sitting posture, not in the left lateral position, if you make the patient sit, the blood tends to gravitate to the stomach from the esophagus. So it will be any bleeding lesion, especially the variceal bleed, if it is present, there will be flooding. The flooding will, disappear, and you will be able to see the varix. You can band it better. So this is the way we can actually tackle the variceal bleed. You're not audible.
Show in the hand.
No, I can't.
Don't show in the hand.
Okay, now
Yeah.
actually I'm sorry, I was mute. So that answer to the question of Dr. Kishore. We have one more question from Dr. Lalit Kumar Raghav from Gurugram, and he wants to know, in case of upper GI bleed due to peptic ulcer, which should be the preferred proton pump inhibitor, according to your opinion?
Yeah, it's a bit difficult question. I think proton pump inhibitors, when it comes to the efficacy, I think we have almost all drugs are same. So the IV preparation, we have starting from omeprazole to esomeprazole to pantoprazole, and even rabeprazole is also there. So you can use any one of them, whichever you are familiar with. Only point I would like to make is if there is a drug-drug interactions, especially if there are patients who are on antiplatelet drugs. So it's prudent to use something like pantoprazole or esomeprazole. Otherwise, there is not much of a thing to choose between the proton pump inhibitors.
Okay. One question which I believe you already touched upon in your presentation, and doctor wants to know, how can we differentiate between upper GI bleed from lower GI bleed, in particularly in patient having melena? You made a mention that if the patient is having hematosis, then there is no question the patient is suffering from upper GI bleed. But there may be cases when the patient is having melena, and when you do the RTS, then also you made a mention that 15 to 20% of the patients, they might not have any bleeding in the aspirate. So in such case, how would you differentiate between upper GI and lower GI when the patient is having melena and RT aspirate is negative?
Yeah, it's a good question, because it has got bearing on the treatment, whether you have to do an endoscopy or do a colonoscopy, because patient is sick, bleeding, and doing a bowel preparation. The colonoscopy warrants a bowel preparation. If it's an upper GI endoscopy, we can just subject him for upper GI endoscopy. So I get a lot of references from our colleagues or physicians they say that this patient should be, they will request for a colonoscopy, but we, in our judgment, after coming over here, we decide to do an endoscopy. So the few points which we actually help that or go more in favor of upper GI bleed is that if there is a quick bowel sounds, it's probably the upper GI source. And if the BU and creatinine ratio is more, then it's probably goes more in favor of upper GI source. And if there is a hematemesis, there is no question. It's a pointer that it's mostly from the upper GI source. And artery hemorrhagic aspirate on Riles tube aspiration, it's mostly from the upper GI source. So in case it's a bleeding from the small bowel or from the right colon, then also you can get melena, but you will not find the hyperactive bowel sounds, and BU and creatinine ratio may be lesser, and there may be other clues pointed towards possibility of colonic lesions.
Oh, that's great. The next question, which again you touched upon during your presentation, the question is, you made a mention in your presentation that the patient is having upper acute GI bleed, then you may require to stop, discontinue all the antiplatelet and the anticoagulant in case the patient is already taking those medications because of the pre-existing cardiovascular diseases. So you made that mention, but you didn't mention, so the question comes from Dr. Gopalan Jalandharan from Trivandrum and wants to know what's your protocol of restarting antiplatelets?
Yeah, this is a very good question. If there is no pressing need, if, as I just said, if a patient has not undergone any PTCA or, the concern is the cardiology standpoint, the concern is the stent block. So, in fact, our cardiology friends tell us that don't stop antiplatelets and you do whatever you want. We are not going to stop. So, that is the thing. So try to give as far as possible the smallest dose of aspirin and go ahead and give a IV PPI. But if the setting is not that, then you can probably stop antiplatelets maybe in about 3 to 5 days time. You can restart the antiplatelets. Probably you can start with ecosprin first and then you can add on the clopidogrel if the situation warrants.
Okay, so you can assure at least within 3 to 5 days to the cardiologist, yes, that if it is mandatory to reinstate the antiplatelet therapy, then probably 3 to 5 days. But sir, yes, would you require to evaluate the patient again by doing endoscopy before you reinstate?
No, certainly, we will have to do the endoscopy in any case because that's very important. We have to do the risk assessment and we have to find out what is bleeding and we have to look at the characteristic features of the lesion, bleeding lesion, whether it's an ulcer or any other non-ulcerative lesion, whether it is a high stigmata of bleed like jet bleed or any blood covering or clot covering the ulcer. So when those things are there, we have to be a little bit more careful. And if it's already the just a visible vessel or it's a no blood clot, if there is no bleeding signs, we can probably start or restart the antiplatelets much earlier.
Okay, that's great. So here we goes to the next question, and it comes from Dr. Sharda Jali from Kalaburgi, and her question is, how to control severe bleeding in ICU where the patient is already in shock, apart from pharmacological treatment?
Okay, thank you, Sharda, for attending and asking the question. Okay, Sharda is my classmate. Okay, yeah. See, the problem is GI bleed in the ICU setting. I did not touch upon that because of the time constraints. One of the commonest scenario is the stress ulcers that can cause bleeding because of either drugs like NSAIDs or anticoagulation, or because of the mechanical ventilation, they tend to have stress ulcer bleeding. So ICU setting, if this is the bleed, anyway, we have to do an endoscopy with intubation or without intubation, as the case may be, and we will be very in a relaxed mood if the patient is already intubated and if the intensivist or anesthesiologist is around, because they will be taking care of the hemodynamic stability and overall patient care. So if there is a bleed from this mucosal lesions, as I mentioned, stress ulcers, we can do a hemospray, or you can, if there is a bleed from the ulcer, if you find if there is any jet bleed or a profuse bleeding, it can be tackled by way of epinephrine injection or by way of the hemoclip application. But hemospray is one thing of late we have been using more and more often, especially in these kind of settings.
One interesting question, when endoscopy fails,
Yes.
then what is next?
Yeah. Endoscopy, failure of the endoscopy or the endoscopist, it's a bit of a sensitive question. Here, the failure depends on the skill of the endoscopist and the setting where the endoscopy is being done, and the kind of backup you have. This is very important. Suppose you have done the endoscopy, you are able to tackle the bleed, but still there is a rebleed that's happening. So you can go ahead and do a repeat endoscopy, and probably this time use a better hemoclip or even OTSC clip, or you can use a slightly different method of
Hello.
सर आई थिंक उमेश सर, अशोक सर, उमेश सर का नेट चला गया है, मैं उन्हें कॉल करता हूँ.
Yeah, if you can call him. I think he has lost connectivity in between. Hello, Dr. Umesh, can you hear us? So sorry for this technical interruption. Probably Dr. Umesh Jalihal has lost his connectivity in between, and our technical person is guiding him, and I'm expecting him to be again on the screen maybe in few seconds.
Sir, he will be coming in 2 minutes.
Yeah. So meanwhile, I would request our audience, please be online, and we are trying to get Dr. Umesh Jalihal as soon as possible. Yeah, I think he's back.
Yeah, I think there are some issues.
Yeah, we can understand, sir.
Yes.
So, sir, if we can go to the next question, I think now it's fine. In the treatment of peptic ulcer disease bleed,
Okay.
would you recommend the use of only epinephrine injection? Question mark.
Yeah, I mean, I think if it's a small bleed, and if you look at the stigmata of the bleed, if it is just an ulcer, visible vessel, or if it's a clot, adherent clot, we can just probably do an injection and stop the bleed. Or if the endoscopist does not have the proficiency or the skill to perform, or the availability of other methods are not there, we can do probably only epinephrine injection, and if the hemostasis is achieved, we should be happy enough and be done with it. But if there is a the high chance of rebleed with only single therapy, especially if there is a jet bleed or if there is a blood oozing from the ulcer bed. So under such circumstances, probably they have to be probably referred to another center if there is a rebleed.
Okay. So we have one more question, and this question is from Dr. Sanu Hubli.
Okay.
When would you plan for endoscopy in severe hematemesis? The timing, though you touched upon somewhere in your presentation, but if you wish to, further have any emphasis on that point.
Okay.
Timing of endoscopy in severe hematemesis.
Yeah, if there is a severe hematemesis, the priority is to first achieve the hemodynamic stability as far as possible. Okay. And, there should be IV axis, ABC, as I said, do the resuscitation initially. And you can even put a right tube and give a stomach wash and take care of all the things that is possible. And then try to do the endoscopy as early as possible. As I said, roughly it would be around 12 hours or 24 hours as far as possible. But if there is an ongoing bleed, patient has got continuously hemorrhagic aspirator, if the right tube is in place, and if his patient is having ongoing melena, and if there is a hemodynamic instability, we should intervene as early as possible.
One more question from Dr. Sharada. The
Yes.
patient comes with hematemesis, patient is already in shock, and known case of cirrhosis. Would it make your management different?
Yeah, cirrhosis, portal hypertension, and severe bleed, and patient comes with shock. Of course, here in this case, again, initial resuscitation measures, as I just now said, all these things have to be done. And in general, in this scenario, we have to give actually pharmacological agents like terlipressin or somatostatin or octreotide, whatever is available handy. We should quickly give that and try to control the bleeding first. And as we control the bleeding with pharmacological agent, also give them the colloids and the blood to achieve the hemostasis. Quickly get the blood pressure up and get the heart rate under control, and try to give them these therapies. And once the patient is in a position to undergo endoscopy, only endoscopy has to be done. If a patient is in a very state of shock, and if in mental confusion and the saturation is plus minus, if it's low, we should be careful while doing endoscopy. We may have to probably take the help of the anesthesiologist, intubate these patients, and then do the endoscopy.
Okay. Sir, another question we have. What is the role of interventional radiology in the management of acute upper GI bleed? Interventional radiology role.
Intervention radiology, as I said, any emergencies, it's a multidisciplinary approach, is a best approach in tackling these patients, because upper GI bleed involves the support from the treating physician, the gastroenterologist, and ICU team or ER team, and the surgeons. And the intervention radiologist also has to be kept on a standby in case if there is a large bleed, and if the endoscopy is done, then there is a rebleed. Under such circumstances, we have to tackle this patient by way of angio, placing the catheter and doing a embolization, or giving a vasopressin through the catheter. That's one for the non-variceal bleed. In case of the variceal bleed, if it's a large amount of bleed, as Dr. Sharda was saying, if patient is in hypotension, in a shock state, we have to be prepared to do an urgent TIPS in this scenario, especially if the patient has got cirrhosis, portal hypertension, and massive bleed. So without, sometimes we will not get an opportunity to do a effective endotherapy. So we may, or if it's a bleed from the fundal varix, we may quickly do the what is called as TIPS or transjugular intrahepatic portosystemic shunt placement. That means you place a stent by transjugular route into the liver, connecting the portal vein branch to the hepatic vein branch, thus decompressing the portal venous system.
Okay. Sir, we have one more question. If you permit, I will take that
Yes.
question.
Yes. Yeah, I think.
When would you?
Yeah.
When would you call for the surgical intervention in the management of upper GI bleed? When will you call surgeon?
The surgeon comes into play under following circumstances. Once there is a associated the complication like perforation, in addition to the GI bleed, if there is a perforation, if there is an obstruction like a duodenal obstruction, or if there is a malignancy, these are the situations I think a surgeon has to be almost be there starting from the initial management till the end, because the surgeon will play a major role. That's one. The second scenario is if there is a failure on the part of the endoscopist to control the GI hemorrhage, if it's a bleeding from the gastroduodenal artery and there is a requirement of a lot of blood transfusion, patient not getting better, and we are not getting to, getting his pressure up, and we are not able to achieve the hemostasis. Under such circumstances, the surgical colleagues have to be there in the team, and they will take over if there is any failure on the part of the endoscopist.
Yeah, that's perfect, sir. Sir, we have a question from Dr. Irana from Gadak.
Yes.
And the question is, choledochal cyst prognosis and treatment of H. pylori in children. If you have any comment on that.
I think there are two different questions. Choledochal cyst.
Yes, sir. And the second is treatment of H. pylori in pediatric patient children.
Okay. Choledochal cyst, actually, of course, it doesn't fall into the category of upper GI bleed today. It's not in the purview. Probably, of course, choledochal cyst needs surgical management following, MRCP. I think it's altogether a different question. The H. pylori treatment is important even in children, because even the bleeding in children, the H. pylori can be there, but it's less common as compared to adults. So we need to eradicate H. pylori on the same principle just like adults. Maybe we'll have the dosage of the drugs may be slightly different. Otherwise, by and large, it's the same principle.
Okay. Sir, I will take last question with your permission.
Yes.
And the question is interesting. Now, you had a practice including upper GI bleed management as well as non-acute bleeding related endoscopy before COVID, during COVID, and post-COVID. So
Yes.
how do you think your endoscopy treatment, whether emergency for acute upper GI bleed or maybe a planned endoscopy, upper GI endoscopy, how would it be different from your previous practice?
Yeah, as I told in the talk, in I think one of the slides, as far as the upper GI bleed is concerned, it's a GI emergency. Whether it's COVID, no COVID, we need to actually tackle these patients.
So you
there's
showed
not much of a there's not much of an issue, or there is not much of a difference in terms of the timing and the urgency with which it has to be done.
Okay.
Of course, if it's any elective procedure, doing an endoscopy for dyspeptic symptoms, endoscopy for gastroesophageal reflux disease, or endoscopy for like a check endoscopy for certain these ones, those things can wait. But if it is for the GI bleed, we actually have to take personal protective equipment, help, and we have to take all due precautions, and we have to follow all the hygienic measures, whether it's endoscopy suit or endoscopy equipment or the endoscopy staff. we have to take all due precautions and go ahead and do the endoscopy if it's a GI bleed, whether it's a minor or major, because till you do not know whether it's a will come to. So, endoscopy, has to be done, but
Okay, sir. I think here we come to the end of all the questions. Probably we have taken all the questions from the audience, and our session was scheduled till 7 o'clock, and now it is 7:30 p.m. So
Yes.
we can understand. I mean, we have a good number of audience today available and participating in this webinar. So the last part of our today's webinar, let me put on record our special thanks.
Okay.
So, Dr. Umesh, thank you so much for such a nice presentation and taking us through your experience, your case studies, your real-time clinical practice in the management of acute upper GI bleed. Thank you so much, sir. And I also wish to put on record our very special thanks to all the doctors who took out the time out of the busy schedule and joined us for this webinar. So, doctors, thank you so much for joining us for this webinar on the topic acute upper GI bleeding. In case we are missing any question, what I will do, I will be transferring all those questions to Dr. Umesh, and then probably if you can locate your email address, we will be try to get back to you. So that's all. Thank you so much. So Dr. Umesh, you have any concluding remarks so that we can conclude our session?
Yeah. Am I audible?
Yeah, we can hear.
Yeah. Okay. Yeah, I think I must thank German Remedies and Zydus for organizing this important meeting, which is continues to be the common problem even during this COVID pandemic time. And I also thank the friends, colleagues from various parts for joining today's webinar. And thanks for the opportunity. If there are any questions or if there are any doubts, anything regarding the endoscopy, regarding the subject, you can actually get in touch with me through our email, or our mobile numbers are there with most of my friends and colleagues. Thank you so much for again the opportunity. Thanks and good night.
Yeah, thank you so much. Please do take very good care of your health and stay safe, and good night, sir. Thank you.
Okay. Thank you.
So much.